Hello, I'm Richard Penson, and on behalf of CME Outfitters, I am delighted to welcome you and thank you for joining us for today's podcast entitled Confusion on the Horizon, Novel Therapies Emerging in the Treatment of Endometrial Cancer. Today's program is sponsored by a joint educational grant from AstraZeneca Pharmaceuticals and Merck & Co. Incorporated. My name is Richard Penson. I'm a physician at Mass General Brigham in Boston, associate professor at Harvard Medical School, and I'm the IRB chair at the Dana-Farber Harvard Cancer Center in Boston. And I would very much like to welcome my colleague, Matt Powell, who is a gynecologic oncologist, chair of the department in Washington University in St. Louis, Missouri. He's also chair of the NRG-GOG Endometrial Cancer Committee, and it has a fabulous wealth of knowledge about endometrial cancer, maybe the best perspective in the country on what's happening and where things are going. Welcome, Matt.
Well, thank you, Richard. And that sets a pretty high bar. Hopefully we can live up to that here today. So
You
thank you
have.
so much for inviting me, and excited to talk about one of my favorite subjects.
And I think kudos is due you. You've seen endometrial cancer change from sort of an orphan opportunity to being one of the very few cancers where there's a rising incidence and mortality. So never more pressing. In the year after it tragically it has a worse mortality than ovarian cancer in our country, which is quite sobering. So we want to look at the overview of the latest data for emerging therapies in the therapeutic landscape for endometrial cancer, some of the mechanisms of actions, the difference between DMMR and PMMR, whether we add PARP inhibitors, and a whole bunch of things. But maybe you could start particularly with sort of the things that really struck you from ESMO 24.
Well, great. And I think when I'm introducing endometrial cancer to maybe a naive oncology audience or young trainees, we talk a lot about how endometrial cancer looks a little like breast cancer, looks a little like colon cancer, and looks a little like ovarian cancer. There's a lot of crosstalk among those and sharing a lot of targets. We have the estrogen targets, much like in breast cancer. We have the mismatch repair targets, like we see in colorectal, and certainly the DNA damage repair that we've been focusing on in ovarian cancer. So the take-home message there is ovarian cancer is not one cancer. And I think when we talk about exciting things out of recent meetings, I do think the antibody drug conjugates certainly are getting a lot of press. We saw several TROP2 or a couple of TROP2 presentations at ESMO that, when we're seeing 30-40% response rates from some of these new antibody drug conjugates in recurrent endometrial cancer and carcinosarcoma, we're seeing even some of these higher response rates. We know that the antibody drug conjugates are going to be a big part of the future of care of these patients.
Yeah, fabulous. You brought up the colorectal cancer. Do you want to just say a bit about the difference between Lynch syndrome and silencing of the promoter, and how different it seems to be, our experience in endometrial cancer as opposed to colorectal cancer?
Yeah, I think, we have a lot of patients coming in and asking for dostarlimab because they know about the rectal cancer data where, these small series of patients where all these patients were having a complete response to their dostarlimab. And again, most of that is Lynch. Most of those patients have germline tumors. Most of what we see in endometrial cancer is promoter methylation of the MLH1 gene. And that knocks that out. And it tends to probably have a little more heterogeneity. Patients tend to be a little older when they get that. It still represents a target. We had some hint that perhaps Lynch-associated endometrial cancer was more sensitive to checkpoint inhibition than promoter methylation. But in most of our large studies, that hasn't been borne out. Either not powered well enough to tell. I mean, there's certainly been a little bit of a trend towards that we see better responses in Lynch or Lynch-like cancers. But most of what we actually see is the promoter methylation type, the somatic change driven by that MLH1 promoter.
Yeah, I mean, I think in GY018 with pembrolizumab, it was really interesting that when they presented that data about that methylation, there still seemed to be a very significant benefit when you have deficient mismatch repair, which is really reassuring. And in this backdrop of PDL1 not being a predictive marker, I was curious about whether you think that the tumor mutational burden is going to sort of come through as a potential identifier, or P53, more prickly tumors, because there are going to be other predictive biomarkers that really pick out the patients who get the biggest margin of benefit. You have a better granular sense of the data. Do you have a sense about that?
Oh, I think you're right on target there. The PD-L1 marker probably has very limited role in deciding which patients receive checkpoint in endometrial cancer, especially probably in our patients that are getting PD-1 inhibitors. There seems to be even less predictive nature of PD-L1 staining. For the DOE study, there was this hint that PD-L1 staining may have some association, but I would think most of our money is in the tumor mutational burden. And as you mentioned, we have this translational science from the Ruby trial that suggests the P53 mutated group is uniquely also sensitive to checkpoint inhibition when combined with chemotherapy.
Mm. I heard we might even get that subset group more clearly from DOE before we get it from GY018. I do think there's at the same time as there's a lot of excitement that we are really splitting apart these lumped groups into really, it's beautifully eloquent science to get a real sense of, okay, in this patient, in this particular molecular fingerprint, what can we expect from therapy? How do we pick better combinations of therapy? I was very interested in that there seemed to be a sort of later diversions of curves with the durvalumab. Are you able to speak to that from the DOE study?
Yeah, I think, again, I don't know if I'd make too much of that yet, but when we do a lot of cross-trial comparison, we can sit and hold things up a little. I don't know what to entirely make of that. I think excited to have more tools. The DOE, obviously added in the PARP inhibitor too, and I think we'll find that group of patients, perhaps with P53 or perhaps with some molecular signature, are best treated with a combination of checkpoint and PARP. All these things are quite exciting for us at this time, and I think the other thing to add in is then you also have to think about, where does HER2 fall in all this? We have layering on top of all this new strategies for managing that, both in an upfront setting using trastuzumab or pertuzumab combination versus now in later lines of therapy, the TDXD combination, as we'll probably get to, but very exciting findings there.
Yeah. So let's talk about ADCs. What's your experience? What data do you find most exciting?
Well, I think we're seeing a lot HER2 directed therapy, and I think both in the 2 and 3+, and perhaps we'll have more data in the 1+, because we see a fair bit of that when you look at endometrial cancer, and it may not, and I should say it's not seeming to be limited to just the serous cases, carcinosarcomas, the grade 3s, and even some lower grade tumors. We're seeing this lower level of HER2 staining. Now, some emerging evidence to say that these tumors actually do worse, so they are more likely to recur or progress. So having additional tools to direct towards these cancers is going to be very valuable in the future. Perhaps this bystander effect, where we can we know our cancers are heterogeneous, where we have areas that are staining 1, 2, and 3+ across the cancer, and hopefully we're seeing these results of kind of long-term benefit with anti-HER2 directed therapy towards that. We also have the folate alpha ADCs, and I already mentioned TROP2, the B7H4, and I think we're seeing emergence of data that looks like markedly better than we had with single agent chemotherapy. If we look now, where's our bar in endometrial cancer? If we look at second and third line chemotherapy, we don't have great numbers after chemoimmunotherapy, because we haven't done those studies yet. But even before we added immunotherapy, our best response rate was around 10% for doxorubicin and around 10% for for paclitaxel. So when we're seeing 20, 30, 40, and as high as 85% response rates with ADCs, we know we're moving in the right direction.
Yeah. Do you, as the committee chair, do you have a sense about regulatory approval? Do you feel like with new agents with really impressive efficacy, we are in, like myeloma, we're sort of, I can't remember exactly, I think there's like 8 drugs approved in myeloma based on phase 2 trials, and there is a wish for the American people to have access to effective drugs, right, to try sort of them. And you don't have the legislation, but we absolutely have the passion. Do you have a sense about that, the accelerated approval and supporting trials that are needed? Where is the bar in terms of these new agents?
Yeah, I think 2 comments about that. One is we're seeing this pan-tumor approval. The Tropion trial, which Anna Unken presented at ESMO, was another TROP2 targeted ADC, Dato DXD. That had response rates 42% in platinum-resistant ovarian cancer, 66% in platinum-sensitive ovarian cancer, and 34% in endometrial cancer, to where, you can see perhaps pan-tumor approvals based on these large phase 2 multi-arm studies, where we're seeing you have the marker and quite nice response rates across the group of tumors. And I think that probably regulatory pathway is very impressive for people. So, and as I mentioned, I think if you have something probably greater than 20 to 30% response rate in the second, third line, that's a winner right now. We don't have anything.
Right.
We used to have lenvatinib pembrolizumab second and third line, which again, had that 30+% response rate, but we don't have data now checkpoint after checkpoint. If they get checkpoint up front, we're not real sure how lenvatinib pembrolizumab is going to perform. So I think we have a wide open frontier and plenty of room for new medications.
Right. The one of the things I say to patients nowadays is, because it's ever so easy to say, oh, I'm going to do next generation sequencing, and I'm sure we'll find something useful. Or the same with HER2, of the positive tumors, only 10% are 3+. And so it was very helpful for the NCCN to approve 2+ and 3+. And we have a lot of trials looking at low expression folate receptor and HER2 that really seems to be an opportunity for new and more effective drugs to really demonstrate their efficacy. When it comes to HER2, do you feel like that was an appropriate NCCN approval?
Oh, I think so. I mean, I think you look at what was the initial trial presentation where you had near 85% response rate for the 3+, and it fell off for the 2+. The updated, at least what we see on their website, it's a little lower as that data matured. That response rate, I think, once they got everything in, but still far better than anything else we have to offer these patients. So yeah, I completely agree. I'm not on that NCCN panel, but I certainly agree that they did the right thing, proving that. And again, we'll see what 1+ looks like in the future, and then whether we can give HER2 directed therapy after HER2 directed therapy. From both ADC standpoint, within the Destiny pan-tumor, there were a lot of patients that had prior trastuzumab, and they seemed to respond similarly to those that were naive. But we might worry that giving prior ADC may downregulate that receptor to where, we may have to, sequencing may become very important in that space.
One of our fabulous investigators, Oladapo Yeku, is looking in cell lines at exactly that: resistance, escape mechanisms, downregulation of target. Many of the clinical trials now exclude patients who had an ADC against that previous target, or ADCs with the same payload. And I think that is sort of become a culture. And so Claudin-6 and the B7H4 ADCs are really exciting as the sort of next generation. The Pux-Itatug, the Blue Star study, AZD8205, do you have any experience of using that?
I haven't used it, but I've obviously seen some of the at least initial discussions about some responses. Is that a study you have open at your institution?
No, but I thought it was quite exciting. Sort of their escalating overall response rate of 21% fundameric Bernstrom is definitely can pick good agents. I think the trastuzumab deruxtecan was just splashed on onto our screens in 2023. Very exciting times. Can we talk maybe about some other things? So we touched on ADCs. Can we just come back to the PARP inhibitors? Do you feel like there's any other opportunities, the WEE1 inhibitors, any other DNA damage response agents that look promising?
Yeah, no, I think we have some of the WEE1 pathway in development. Managing toxicity is a tricky one there. I did, as you mentioned before we get off the topic of checkpoint, has mentioned the B21 study. You saw the publication came out in Annals of Oncology. So B21 is adjuvant use of pembrolizumab and chemotherapy, and then the dealer's choice whether you give radiation or not for patients with newly diagnosed high-risk endometrial cancer, mostly stage 3-4. And the overall intent to treat population looked about the same. So the checkpoint didn't seem to add much there. But if you look carefully at the DMMR population, which was a planned analysis, it just wasn't powered. Back when this trial was implemented, we didn't quite know how many patients we'd be seeing of each group, et cetera. Nonetheless, that cohort looked striking. So we may see that we'll be able to add checkpoint to these earlier patients. So 3C1s, 3A patients with mismatch repair deficient endometrial cancer, perhaps addition of pembrolizumab to their chemotherapy is the right approach.
Yeah.
And that I believe there's going to be another publication coming out looking at that in more detail within the JCO.
So this was an NGOT-GOG study. I just think this sort of international collaboration now is so admirable. The pharmaceutical sponsoring of these things and then everybody working together is just tremendous. I was one of the people who was really worried about GY018 and Ruby being designed with progression-free survival as the primary endpoints, and was worried that in the end it would delay getting these effective agents to market. That doesn't seem to have been the case. Using PFS really does seem to have been an effective strategy.
Well, I think it probably helped with Ruby having that OS benefit fairly early on. There's here in the United States we're able to use pembrolizumab second and third line pretty easily. Most of the rest of the world was a little harder. So I think that likely drove that OS endpoint earlier in the Ruby trial than we see in the GY018 study. I think consistency across PFS and the different subgroups is another part of how that FDA approval happened.
Yeah.
So, I mean, it's exciting. I think, how much the addition of chemotherapy and checkpoint inhibition adds, or whether they can be given sequentially or whether that combination is needed, we don't know. The nice thing is it's well tolerated to combine it. So there doesn't seem to be an added safety signal combining chemotherapy with immunotherapy.
Yeah, which is great. And so one of the things that came out looking at the data at ESMO was, say in GY018, doubling the CR rate. Do you really feel that it's going to take us a very long time to lose chemotherapy as part of the armamentarium for the DMMR patients?
So we tried to launch a study to look at that. So it would be the DMMR population from 018 and platinum taxane plus pembrolizumab versus pembrolizumab alone. And it just, people weren't comfortable enough with it yet to make that leap. It just, part of it is that things look so good with the carbotaxyl pembro that people are hesitant to mess with it. The other thing is those patients are doing so well, it's a very large study to do that de-escalation. And as you know, in cancer care, de-escalation is hard.
It's very hard.
When we're winning, it's hard to go back a little bit. And I think that it'll happen eventually. And I think, we have a few other trials that are out there that are looking at immunotherapy alone versus chemotherapy. And we know chemotherapy doesn't do a whole lot for mismatch repair deficient cancers from, the PORTEC-3 study that didn't seem to add a big benefit. But we don't know how that interaction is when you give chemo with immunotherapy. Maybe that's part of the secret sauce.
Right.
So I think, as you mentioned at the start of this broadcast, there's so much excitement within endometrial cancer. We ran 5 large randomized trials throughout the world, all at the same time. We have several going on now. It's really kind of unheard of progress that's being made in endometrial cancer.
Yeah, and such rapid progress. If you think about the de-escalation, it's taken decades to safely limit therapy in breast cancer. And so it's going to take a little while. Can we stick on Keynote B21 just for a moment? Because
yes,
I just want to celebrate moving the really significant advances that have happened for advanced recurrent or metastatic disease into the frontline setting. And so just to drive that home, the DMR population had a hazard ratio for disease-free survival of 0.31. I mean, that is just absolutely fantastic. One of my concerns, though, was that it's a very broad group, a very heterogeneous population of patients, some relatively low risk by stage, but scary histologies got into that trial. And the pMMR hazard ratio was 1.2. Now, it overlapped unity, confidence intervals 0.91 to 1.57. But this was a big study. The whole study was more than 1,000 patients, pMMR 814 patients. Do you worry that there's some patients who are exposed to immunotherapeutic risk with that sort of very shotgun approach to therapy?
Yeah, I think at least my take home right now is the DMMR population is clearly different.
Staggering. Yeah.
Staggeringly different. We may find that there is some pMMR patients that would benefit from the addition of checkpoint in the earlier stage. And again, maybe that P53 will pop out, when the translational science is done on B21. But at least right now, I would very much just limit treatment to the DMMR population. I think, there's even potential for slight harm in the pMMR population. Yeah. Perhaps the pMMR really need to wait and be given lenvatinib pembrolizumab if they recur, an anti-vascular approach with checkpoint. Maybe that's going to be much more active for them.
Right.
So yeah, I don't think in the upfront setting we should be giving all these patients checkpoint.
Right. There was a couple of great science papers just recently looking at the tumor microenvironment, and there's probably more to unlock about that. The other thing that was really interesting about it is the duration of therapy. So dostarlimab 3 years, pembrolizumab 2 years. This was 1 year of therapy. And so I have at the moment a patient who's got a POLE mutation who had terrible pulmonary metastasis in a late presentation, who's had a miracle response, but she's doing paclitaxel carboplatin. And we're planning a year of pembrolizumab. And so I was curious about your take in the adjuvant setting. So in breast cancer, they reduced PARP inhibitors to 1 year. Do you have a sense about the right thing to do for that in terms of duration of therapy?
Yeah. So, in our GY020 study, which was the node negative, high intermediate risk patient that's defective mismatch repair, those patients were randomized to a form of radiation, either vaginal radiation or pelvic radiation, versus same radiation plus a year of pembrolizumab. And that study's maturing. We should actually have the data later this year, we hope. And initially I was a little bit concerned with, the press release on B21 that I really thought maybe you need measurable tumor in order for a checkpoint inhibition to work. But I'm thinking GY020 could end up being positive, and we gave it for 1 year. And that hopefully will be enough. A lot of the patients, they feel well, they're doing fine, they have their port in already. They don't want to stop that checkpoint. They feel it's somewhat a miracle. But when you have no measurable disease and your upfront therapy, I think it's a little easier to stop because you start from day one saying, well, we're going to do a year of this.
Right.
And for most of my patients with advanced or bulky disease, like your patient that had lung metastasis, I usually treat for about a year after everything's disappeared on their scans.
You do.
Or, I think that's a reasonable thing. I haven't been going to using circulating tumor DNA, but I don't know, that's certainly something that people are talking a lot about. And
yeah, here you go. I have a patient who's doing marvelously on abemaciclib, letrozole, and metformin, and she desperately wanted ctDNA, and it came up with a P53 mutation, which probably is from CHIP, clonal hematopoiesis, because she's got a radiologic CR on a PET CT scan. And so I said to her, I need artificial intelligence, alien intelligence, to tease out what's the right thing to do. ctDNA, is that there was some talk about that at ESMO?
Yeah, and I think that we still don't know exactly how best to use it. I think one, it's expensive, but so are CAT scans, so is the therapies we're using. So if we can use it to tailor therapy best for patients, so I think would be great. We think we'll be launching a trial through the GOG, looking at earlier stage endometrial cancer patients to try to figure out who needs adjuvant therapy based on, their circulating tumor DNA status. So, really exciting times from that. But I think, using it to decide when to stop therapy, it's a lot of people are doing it. I think it's reasonable. We won't have a study for years to prove it, but so it'll be somewhat anecdotal for quite some time.
Right. Good job. We are running out of time. Any other highlight points that really have been at the forefront of your mind recently?
Well, you mentioned the CD4/6 inhibitors, and certainly something we're excited about. And I think really maximizing our hormonal cue is something we've not done very well with. And if you look at the patients that did not benefit from DuoE, or we'll say Ruby, we have the mature translational science, it's really the NSMP patients. And most of the NSMP patients, or copy number low, are the patients who are ER positive, and they're probably the ones that look the most like breast cancer. So I think those patients need a different strategy than checkpoint inhibition, probably. And that's where hormonal treatment and CD4/6, and perhaps with their P53 wild type status, selinexor, so nuclear export inhibitors, makes sense for that population. And the confirmatory study is ongoing now to know whether maintenance selinexor would be the right thing for these patients.
Very exciting. Good job. Unfortunately, it's time to wrap up our discussions, and thank you, Matt. So let me summarize what we've talked about today. It is an unprecedented time in terms of immunotherapeutics, improving survival, now translating into dramatic improvements in the chance of cure in the dMMR population with B21 as part of first-line therapy, chemo immunotherapy. Lots of new agents, especially the antibody drug conjugates and new targets in these ever better refined subgroups. So to receive CME CE credit for today's program, complete the post-test and evaluation, and you'll be able to download and print your certificate immediately upon completion. Remember, this is the second of a 6-part podcast series on gynecologic cancers. Next month, I'll be hosting a discussion on our expanding options with checkpoint inhibitors and immunotherapeutics for the frontline setting in advanced and recurrent endometrial cancer. And I hope you'll be able to join us for that. We'll be archiving this and future podcasts in the series on the Oncology Hub at cmeoutfitters.com, where you can find a wealth of excellent resources for both clinicians and patients. And again, thank you, Matt. Good to see you. And thank you for joining me for this very important discussion. And thank you to you, our audience, for tuning in today and for providing the very best of care for patients with endometrial cancer.